Good morning. Time now a few minutes after 8 o'clock in the morning in Tokyo, Thursday, April 14th, 2022. Welcome to another edition of online morning seminar organized by the World Bank Tokyo office. My name is Koichi Omori. I am Senior External Affairs Officer of the World Bank based in Tokyo. We organize these seminars introducing the latest report presented by the World Bank economists and specialists. And from time to time, we have senior managers as our speakers discussing what the World Bank does to achieve our twin goals, eradicating extreme poverty and boosting shared prosperity. Currently, we are running a Japanese national recruitment program to hire more Japanese nationals at the World Bank Group. 8 junior professional officer or JPO positions and 9 mid-career positions are being posted currently on our website. So please apply actually. Some of our morning seminars during the application period are aligned with this recruitment program. Today, we have a pleasure of having Aparna Smana-san, the practice manager for health, nutrition, and population in East Asia and the Pacific region, connecting from Sydney. Aparna is the hiring manager for health economist specialist position based in Delhi. This is one of the positions currently posted on our website. We have a extreme pleasure to have one of the hiring manager of the ongoing recruitment programs as a speaker. Aparna, how are you? Thank you for joining us this morning.
Thank you, Coach-san, and good morning, everyone. It's a real pleasure to be here with you all this morning and to be able to share with you some of the work the World Bank does in health, nutrition, and population in the East Asia Pacific region. Thanks so much for your interest in the bank's work. So I hope to speak for about 20-25 minutes, sharing with you, some background on the region and what we do, and then there'll be an opportunity for you to ask questions as well.
Okay, great. Thank you. So before formally asking you to start your presentation, let me make one more housekeeping announcement. After the Aparna's keynote presentation, as usual, I'll read the questions that we received already from our viewers. If you did not have opportunities to send your question in advance, please do so by sending your questions using the online form posted on the announcement page of this seminar, or you can simply post your question on the chat section on the YouTube screen as usual. I'll read your questions after Aparna's keynote presentation, asking her to respond. So over to you, Aparna. Please come in to start your presentation. Thank you.
Thank you, Koichi. So hello again. The East Asia Pacific region, as you know, is incredibly diverse. It has some of the largest countries, some of the smallest countries, some of the richest countries, and some of the most fragile and poor states. It was and is likely to continue, despite the setbacks of COVID, to be a powerhouse of economic growth and poverty reduction. But on top of that, East Asia Pacific region countries are incredibly vulnerable to climate change, and yet include some of the largest contributors to total greenhouse gas emissions. So as many of you know, EAP is really a very diverse region, requiring us to come up with a range of different strategies to help respond to its many needs. Next slide, please. As in most other parts of the world, the impact of COVID-19 on economic growth was much worse and more widespread than previous crises in the East Asia Pacific region. But there's also been a lot of variability. There's been deep contraction in a few countries and much less in others. Next slide, please. And to a region that drove poverty down quite consistently over the past few decades, COVID-19 was a real setback. Under different scenarios, poverty could rise as much as 20 or 22 million from the 14 million that would have been expected without COVID. Next slide, please. So how does the East Asia Pacific region do in terms of health, nutrition, and population indicators? Pre-pandemic, the East Asia Pacific region's performance on the World Bank's Human Capital Index was reasonably good on child survival and adult survival. However, on stunting, the EAP region performs better than only South Asia and Sub-Saharan Africa. Next slide, please. The epidemiological transition was well underway by the early 2000s in the East Asia Pacific region, with a decline in communicable diseases and rapid increase in the burden of non-communicable diseases. However, the first generation challenges still persist in many countries, especially some of the poorer parts of East Asia Pacific. And malnutrition, in particular, associated with stunting, is very high in many countries in our region. And taking a closer look, next slide, please. Taking a closer look, if you can move on. Yeah, taking a closer look at stunting in particular, progress towards reducing stunting has been highly unequal in the East Asia Pacific region. Most of it has been driven largely by China. And if you look at stunting, the prevalence of stunting against economic growth, the prevalence of stunting is higher than would be expected based on income. Philippines and Indonesia being examples of this. Next slide, please. EAP is also the fastest aging region in the world. Unlike other rapidly aging regions, such as Europe, East Asian countries, however, are getting older before they get rich. This means that EAP countries have not had the opportunity to put in place the systems to manage and finance aging in the future compared to many European countries. Next slide, please. What about health service use? The World Bank and WHO, as some of you probably know, collaborate annually in producing the UHC Service Coverage Index. So next slide. Not sure where you are, but it's, yes, that is exactly where we should be. So the UHC Service Coverage Index is an average of 14 equally weighted indicators that are essential for service use. Now, pre-pandemic, the SCI showed quite a lot of variability within the East Asia Pacific region. From around 2000, when we first started measuring the Service Coverage Index, there were significant improvements in China, as well as developing parts of East Asia, as you can see with the red line and the orange line. However, in other parts of the East Asia Pacific region, Pacific and Papua New Guinea, we've seen some stagnation or even decline in the Service Coverage Index. Next slide, please. The UHC Global Monitoring Report that was published in December 2001, which presented data up to 2019, because that was all the data that we had in terms of household surveys and so on, showed that the rate of improvement in service coverage use has slowed or stagnated in the last 10 years. So the blue dots here represent the annualized growth or improvement in the Service Coverage Index from 2000 to 2019, and the yellow dots represent growth rates from 2010 to 2019. And where you see the yellow dots below the blue dots, that means that the rate of progress in the Service Coverage Index has actually declined, such as in Papua New Guinea and the Federated States of Micronesia, or FSM. Next slide, please. So with COVID and all of the disruptions to service use, we fully expect COVID to have had a negative impact on health service use. Granular country-level data are still being collected. We've got high-frequency surveys and similar things that are collecting data on this. But we already have some data from the Philippines that speaks to this. And what do these data show us? Well, there was a sharp reduction in malnutrition and insurance claims for malnutrition and pregnancy care-related services at both hospital and primary care level. And if you think about these two kinds of services, antenatal care services, malnutrition-related services, and so on, the decline in these services is likely to have a significant impact on the health of children in utero, including long-lasting impacts on chronic health conditions and cognitive attainment in adulthood. In addition, the risk of adverse effects from COVID-19 increases significantly with age and comorbidities. So overall, this reduction in pregnancy care, in TB, in ischemic heart condition related services and so on, puts the health of working age adults at higher risk of poor health outcomes and absenteeism from work. And this is just data from the Philippines that we have, but we expect to see similar trends in other countries once the data starts coming out. Next slide, please. So what about health spending? Government spending on health had increased in the East Asia Pacific region over the 2000s. And if you look at a period from about 2000 to 2019, East Asia Pacific region has had the highest percentage annual growth rate across all regions. This was driven by economic growth as well as increased government allocations to health. However, this increase in government allocations for health was not associated with a decline in the share of out-of-pocket spending. In fact, out-of-pocket spending pre-pandemic remained stubbornly high. Next slide, please. Now, as many of us who work in the health sector know, when the share of out-of-pocket spending for health remains high, that results in catastrophic health expenditures or impoverishing health expenditures. And as the different charts on this slide show, pre-pandemic, impoverishing health expenditures in the East Asia Pacific region were relatively high compared to all other regions in the world. And the highest incidence of impoverishing health expenditures were in countries like Cambodia, Myanmar, and China. Next slide, please. So what do we expect COVID, what do we expect the impact of COVID to be on health spending, on out-of-pocket spending, and so on? So in the past, public spending on health tended to be pro-cyclical. It would increase when times were good and decrease when times were bad. Based on data from 1996 to 2019, the elasticity estimates of public spending were used to project government health expenditures for the next few years. This is work done by several of our lead health economists in the World Bank region, World Bank. Under a historical scenario, public health spending is expected to decline by 1.1% before returning to pre-COVID levels in 2024. Under a pro-health scenario, where governments are able to reallocate more resources to health in the aftermath of crises as well, per capita health spending can be assumed to grow at the same rate as in the decade prior to COVID. But there will still be some variation within that. Next slide, please. Prior to COVID, general government expenditures in the Pacific were already high. So it's estimated that under the historical scenario, for many Pacific islands, such as the Marshall Islands, Tuvalu, Vanuatu, and so on, there will be a decline. The biggest decline in public health financing will be in these countries. In the rest of East Asia, Thailand, Philippines, Mongolia, Cambodia, China are expected to decrease government health spending on health, while Timor-Leste, Myanmar, Laos, Indonesia, Malaysia, and Vietnam are expected to increase government health spending as a share of total health spending based on their past response to economic shocks. So these are projections based on the past behavior of health spending that we expect to see. Next slide, please. If fiscal space is limited, increasing efficiency of spending will become critical. When we look at health-adjusted life expectancy against health expenditures, we find that there is considerable room to improve efficiency in many East Asia Pacific countries, as the charts show for 2000 and then 2019. Next slide, please. So that is a summary of the health context, the health service use, health expenditure context in the East Asia region. So what does the World Bank's portfolio and priorities look like in this region? Next slide, please. When we look at the project development objectives of all of our projects in our current portfolio, this is currently in 2022, this is what we get. As you can see, COVID, preparedness, and health systems feature quite strongly in our project development objectives. Next slide, please. So I'm going to try and summarize for you some of the kind of innovations and trends in our portfolio at present. And already pre-COVID, this is what was happening, but it's likely to continue so. Over the past 10 years, there's been a marked shift from financing infrastructure to a focus on systemic health service delivery issues. From Cambodia and Vietnam to PNG and Indonesia, most of our operations are moving to strengthening primary health care, improving quality of care, and so on. Secondly, there's a greater focus on linking investments to results and performance. The HNP GP has stood out already in the region, so the health, nutrition, and population global practice has stood out in its use of disbursement-linked indicators and other results-based instruments in our operations. And this has actually brought several benefits to both our clients and to how we work. First and foremost, with results-based operations, the dialogue has shifted from fiduciary processes to system strengthening. We're no longer talking about specific bits of procurement in our conversations with government. We're actually talking about reforms and what are the policy actions needed to get there. Secondly, this focus on results-based operations has allowed us to attract investments from other partners. Currently, the partners that we are co-financing with or working with across the East Asia Pacific region include AIIB, DFAT, the Government of Australia, the Global Fund, the Government of Germany, the Government of Korea, and the Global Financing Facility. DLIs, or disbursement-linked indicators, have been used for both health systems as well as service delivery levels at the decentralized level, district, provincial level. And another advantage, or another positive from this, is that the DLI verification processes that we put in as part of our operations have yielded additional benefits that go beyond just proving the DLIs. They've helped improve data quality and improve government management attention to good quality data, strengthening data analytical capabilities, and so on. And we have a DLI operation in Laos that's a very good example of this. And finally, over the past 10 years, we've considerably increased our work on fragile and conflict states in very difficult contexts, particularly in the Pacific. And much of this work focuses on rebuilding and strengthening systems, improving access to quality of care. So examples are operations in Papua New Guinea, Laos PDR, Timor-Leste, and Myanmar. Next slide, please. So just very quickly, looking at the size of the portfolio, over in 2020 and 2021, there was a huge increase both in the numbers of projects as well as investments, most of it due to COVID. In 2022 and in 2021, again, there was the additional financing for vaccine operations, which led to a huge increase in the portfolio again. In 2022, we're beginning to pull away from all of the COVID-related projects. Projects approved this year include a health insurance program for results in Indonesia, a multi-sectoral nutrition project in the Philippines, a multi-sectoral nutrition project in Papua New Guinea, and so on. Next slide, please. And also over the last 10 years, we've been really trying to walk the talk on cross-GP collaboration. And there are many examples of the bank the health, nutrition, and population GP working with other GPs in our operations. The nutrition convergence is one. It's increasingly a reality across sectors in the East Asia Pacific region. In Laos, we have 5 projects: agriculture, social protection, health, education, that are converging in 4 lagging provinces in northern Laos. And in Cambodia, Indonesia, PNG, and a new project in the Philippines, We have close collaboration across GPs on nutrition investments. Then there are other investment projects, increasingly tagged as multi-sectoral. We have iSphere, a project that's co-led by the governance GP in Indonesia. As I mentioned, in Laos, PNG, Myanmar, we have multi-sectoral nutrition projects, Indonesia as well. And then more recently, One Health. So in the aftermath of COVID, a project that was designed in China was essentially a One Health project of health, agriculture, and the environment GPs. And we're currently preparing a One Health project with ASEAN that's led by agriculture, environment, and with HMP Health as co-leads. And then in our analytical work, we again work with many GPs. So the macro fiscal groups on tobacco taxes, with governance on public financial management, decentralization, with poverty on high frequency surveys, and with the energy group on clean cook stoves. Next slide, please. And then just briefly on corporate priorities, gender and climate change are two examples of that. The HMP GP continues to lead the East Asia Pacific region in gender tagging of our investments. So during COVID, there was a brief pause on gender tagging projects for the COVID projects, but apart from that, we've tended to reach almost 100% coverage of gender tagging of our projects. Next slide, please. On climate co-benefits, we've tended to do less well. The methodology was changed, and we've seen a decline in the percentage of projects that are the percentage of climate co-benefits earned by HMP projects, but this is something that we're working on in the hope of improving. Next slide, please. So I'd like to talk a little bit about emerging directions for our GP. In fact, over the past 2 months, some colleagues and I have been thinking through what strategic directions would look like for the East Asia Pacific region going forward. But one thing that's become clear throughout the COVID pandemic is that making progress on UHC is intrinsic to pandemic preparedness. Pre-COVID, we tended to treat pandemic preparedness as this other thing, separate to health system strengthening in UHC. But COVID has taught us that countries with better capacity, well-coordinated health systems responded to COVID better and vaccinated better, and looked after the needs of the poor and vulnerable better. So going forward, a strategic priority in this region would be to link the two, to see them as two sides of the same coin, as part of our support to countries. And there'll be two pillars to this. One will be transforming health service delivery to not only address the needs of COVID, but also other needs, and the other would be to strengthen public health. Next slide, please. So what does transforming health service delivery to meet COVID and other needs look like? Well, to meet surges in demand for COVID-19, countries need support in making healthcare capacity available at the right points in time, at the right places. This implies scaling up, repurposing, and/or redistributing existing healthcare capacity. And what are some examples of the kind of no-regret investments we might make that would help us in responding to COVID and help us achieve UHC goals? For instance, we've seen that there is scope to make extra hospital capacity modular, allowing more critical care capacity to be quickly expanded on demand. Technologies for low-cost modular ICUs are also emerging quickly that would allow investing in ICU capacities at the district hospital level. Then there's oxygen generation capacity in hospital, another example of a low-cost, energy-efficient investment. So these are all examples of cost-effective investments that foster both resilience and efficiency. Plus, increasing infrastructure needs to happen in tandem with increased workforce capacity. And this is another area that countries need support on: the level, distribution, and quality of health workers. And finally, another thing that we've learned from COVID is that some degree of critical care capacity in countries is needed. because overseas referrals, overseas medical care may not always be feasible. And for many small Pacific islands, as well as Timor-Leste, this may turn out to be a priority. Second, primary care. Primary care needs to be prioritized now more than ever. An interesting outcome of the pandemic is that people have shied away from hospitals and sought more primary care instead. Can this be sustained? Using digital health tools, remote consultations, remote monitoring, increasing PHC capacity may well require adjustments in legal and financial frameworks. And this is something we would hope to support our clients on. Ensuring adequate coverage for medications may limit the out-of-pocket costs of primary care, making it even more accessible. So primary care has a key set of roles to play in managing COVID-19 outside of hospitals and providing essential care and sustaining public health services. Next slide, please. Public health is a discipline that's best equipped to deal with pandemics because of its roots in management of infectious diseases. We're finding that having strong pre-existing public health and primary care systems provided an advantage to many countries, particularly where there was a tradition of strong public health primary care linkages. So what are the kinds of investments or interventions we would look to support countries with? One would be implementing appropriate non-pharmaceutical interventions, testing and tracing to control or mitigate transmission. Another would be to implement effective vaccination campaigns. And third, maintain routine public health services and surveillance. So institutional strengthening and coordination for pandemic preparedness and response, establishing or strengthening networks of public health laboratories, particularly at the decentralized levels, and operationalizing One Health in practice. Next slide, please. And last but not the least, as you see in the previous two slides, cutting across our work will be the need to strengthen health management information systems. COVID has highlighted the need to invest in health HMIS and pandemic preparedness. As countries turn towards strengthening core public health functions such as surveillance, they will require significant investments to digitize health management information systems, increase laboratory networks, and so on. So we see this as a cross-cutting area across all of our investments in future. So that's just an overview of what our strategic directions going forward may look like, following the summary of our portfolio at FON. I might just leave it there and look forward to answering questions you might have. Thank you.
Thank you very much for your presentation describing the main issues, key priorities, and even priorities going ahead in terms of the health and nutrition population in the East Asia and the Pacific region. We received several questions in advance from the viewers. Some of those questions are the questions that you already, in a sense, addressed during the presentation. But let me read those questions since these are the things that viewers are interested in asking you to respond. First question, excuse me. First question, I would like to ask one question about UHC. Achieving UHC is one of the biggest global issues, but I think maintaining UHC will be also an important challenges for the countries which has realized UHC. What kind of support can World Bank Group provide for this challenge? Aparna, over to you.
So just to clarify, what kind of support the World Bank can provide for sustaining UHC, right? So I think the most important thing to remember is that with universal health coverage, we talk about making progress towards universal health coverage, right? It's not like there is a point that any country reaches where there is 100% universal coverage. So if you look across the East Asia Pacific region, many countries have made significant progress in towards achieving universal health coverage. And a lot of that progress, I would say, happened in the 2000s when many countries like Vietnam, Philippines, Indonesia, China, Thailand allocated more and more public sector resources to health. Now, many of these countries are also aging rapidly. They have growing non-communicable disease burden. And what that means is that these trends are likely to drive up health expenditures. So to sustain universal health coverage, public health spending or allocations for health from public sector budgets are going to have to increase. But even as they increase, countries will need to do more to spend better, to allocate the resources they have more efficiently. And all across the East Asia Pacific region, both through our lending operations and through our analytical work, we provide support to help countries diagnose inefficiencies and allocate resources more efficiently.
Thank you. Thank you for your response. And let me reorganize my screen. Sorry. Yes. Let me. That was a question from Takeno-san. Thank you for your question. Let me continue with the question that we received from Wakabayashi-san. Thank you for your question. What kind of specific projects are going on in East Asia and the Pacific regions? Each supported countries in the region is different in terms of economic conditions and burden of diseases. How do you integrate those countries into the specific project? So question was not only about the diversity of the countries in the region, but also potential opportunities in the regional cooperation or cooperation across the countries in the region in this sector. Aparna, over to you.
Sure. So as we already saw during my presentation, it's a very diverse region requiring diverse set of responses. So maybe I'll start with Indonesia, which is perhaps our largest portfolio. So Indonesia is a rapidly developing country with with health insurance reform, health service delivery reform that are much more, a mature set of reforms, right, and evolving quite rapidly. So here, the kinds of support we provide, for instance, to the health insurance program for results, the health service delivery operation at present is really supporting the government with cutting edge knowledge on health service reforms from other countries, on innovations in health financing reform, health service delivery reforms, and helping them implement these reforms in Indonesia. And then this is complemented by analytical work. And again, the analytical work brings in a lot of this knowledge and innovation from other countries in the world. And then through our programs for results, our operations, we're able to help the government implement them. Another example would be Philippines. Again, similarly, rapidly developing. Their needs are much more sophisticated in terms of health insurance reform, of service delivery reforms. In the Philippines, we haven't been engaged in the health sector, at least not through operations for the past 10 years or so, but we have had significant programs of analytical work that have helped us stay engaged in the sector, understand the evolving reforms. So post-COVID, when the government needed support, well, not post-COVID, during COVID, we were able to respond with very large COVID emergency response operations, both the first phase, but also the vaccine support. And then also during that time, the government requested support on a multi-sectoral nutrition project, a nutrition project that will work at the local government level to strengthen nutrition, primary care on the supply side, but also strengthen the demand side for nutrition services. Then going across to the Pacific, where we've got very, several fragile states, vulnerable to climate change, where capacity might be limited. And in these countries, we're working really closely with other development partners, DFAT, MFAT, the UN, and so on. Our investments are sort of health systems strengthening projects. So examples in Tuvalu, in Kiribati, and there's a program for results in Samoa that's targeted at strengthening systems for non-communicable diseases. But these really are sort of broader health system strengthening projects that try and bring leverage the resources from other development partners in order to converge those resources on important health service delivery reforms. Another example is Laos. Again, was a fragile state, but it is still a very limited capacity. And here we have a results-based operation with disbursement-linked indicators that leverages financing from the Government of Australia as well as the Global Fund to strengthen service delivery and financing. So that's just a range of different projects and how we support, but I'd be happy to answer any specific questions on that.
Thank you for your responses. Let me continue read the question from other viewers. A question that we received from Kodera-san during your presentation. Thank you very much for your question. Thank you for the timely update. One point which is not mentioned here is access to clean water and sanitation. FCBs and Cambodia still face serious challenges in this regard. What is EAP's strategy on water, sanitation, and hygiene or WASH? Aparna, please.
Thank you. So the Health, Nutrition and Population Group works very closely with the WASH Group, Water and Sanitation Global Practice, the World Bank, in supporting countries with these investments. So a lot of the bigger kind of exclusively WASH investments are actually led by the Water and Sanitation Global Practice, but in many countries from including Laos, Indonesia, Papua New Guinea, Kiribati, we work very closely with WASH colleagues in health as well as nutrition operations.
Thank you for your responses. A question that we received from Dai-san. Thank you for your posting your question on the YouTube screen. Thanks for impressive presentation. I think lack of business improvement is a massive challenge in the Pacific Island countries. How do you think the health project related to the economic progress in countries with few business opportunities? For example, Timor-Leste has hugely dependent on oil and gas for its GDP. Any comment, Aparna, on this point? Thank you.
I'd like to understand a bit more what business improvement refers to, but I think it's a broader issue of stagnation and economic growth, right? Because of COVID and limited economic opportunities. For the Pacific in particular, as well as Timor-Leste, the World Bank's argument is that investments in human capital are absolutely critical. Investments in child health, in nutrition, in education, all of these are really important, just as important as investments in physical capital in order to improve economic growth in these countries. So our approach in Pacific and Timor-Leste is really to improve investments, improve the quality of spending in these sectors through our investments in order to strengthen investments in human capital and therefore contribute to economic growth.
Thank you for your responses. The question from Honma-san, thank you for your question. According to the data in your presentation, PNG appears to be one of the most vulnerable countries in terms of health in the region. Could you elaborate on why PNG is more vulnerable than other countries in the Pacific regions?
PNG, I think, has historically has not had the infrastructure for service delivery or the human resource capacity for service delivery as many other Pacific Island countries. Even Solomon Islands, I would say, probably has a better health service delivery capacity than Papua New Guinea. A lot of that is associated with geography. Many parts of PNG are quite remote, are very hard to access for health services. But over the years, I think there's been considerable fragmentation in the financing for health services. So it's a highly decentralized structure, and the flow of financing from the center to the district always seems to get stuck along the way at many different levels, so that the much needed funds don't receive the lowest level of service delivery at the right time. So it's a combination of sort of the geographic kind of setup of PNG, limited investments historically in the kinds of infrastructure and human resource capacity that's needed for service delivery, as well as significant challenges in the flow of funding for many of these services.
Thank you for your responses. The one more question from Honma-san. Could you elaborate a little more on the linkage between the health and other cross-cutting solution areas, for example, gender, climate change, in terms of analytical works and the project? Aparna, please.
So on gender, I mean, gender actually belongs in the Human Development Group within the World Bank, and it's something that's intricately linked to work that we do in health, education, social protection, and so on. As part of the Advanced UHC Multi-Donor Trust Fund in the East Asia Pacific region, supported by the Government of Australia, we've really tried to step up our work on mainstreaming gender in our HMP, in our health operations, sort of looking at not only maternal health, which is a very important part of reducing the gap in gender outcomes, and we obviously do that through almost all of our health sector operations. We've also been looking at things like increased distribution of females amongst health workers, looking at gender-based violence and the responses of health providers, health facility providers, while strengthening the ability of health facilities to respond to gender-based violence, but also addressing gender-based violence through community-based operations, through community communications that we would do as part of nutrition operations, for instance. So trying to address gender in multiple ways through our health, nutrition, and population global practice. Climate change is slightly different. So as I showed in my chart, there was a time a few years ago when HMP health projects were achieving a fairly high level of climate change co-benefits. The way in which this is measured has changed, and we're seeing a decline, but it is a huge priority for us at the World Bank, improving the climate benefits of our projects, increasing what we do to respond, to adapt and mitigate climate change through our projects. So we're currently looking at our portfolio as a whole and trying to identify entry points where we can do this better. So a very good example is the COVID response project in Mongolia, the additional financing for vaccines. We worked with UNICEF to provide support on the labs that were set up that would have solarized energy. And similarly, when we look at cold chains, we're looking at solar energy, supporting cold chains in many of our other countries. So working closely with the climate change group in order to strengthen what we do through the health, nutrition, population global practice. And certainly analytical work is what we start with to try and understand how we can do better here.
Thank you for your responses. A question that we received from Professor Shimamoto in Kyoto. Thank you for your question posted on the YouTube screen. Your thought, if any, on the role of the private sector in the fight against COVID-19. So the role of the private sector. Thank you.
The role of the private sector has been quite critical from early on in the pandemic when we were looking at PPE, lab supplies for testing, for test kits themselves, and then more recently on vaccines. So in the East Asia Pacific region, we work quite closely with the IFC, and we're looking at how we can collaborate better in order to strengthen private sector contributions to health in many of our countries. So for instance, we are starting to do a very small piece of analytical work to look at vaccine manufacturing capacity in ASEAN, because many of the ASEAN countries, Malaysia, Thailand, Philippines, were quite concerned about the constraints they face in accessing vaccines and are keen to look at how to expand vaccine manufacturing capacity. So again, we're working very closely with the IFC on this, basically looking at what the capacity looks like. And not just for COVID vaccines, but all other vaccines, as well as consumables for laboratory and so on. So extremely important, the role of the private sector, and we are working closely with the IFC to try and figure out how this can be done. Another area in health where the role of the private sector is very important, particularly East Asia Pacific as an aging region, is long-term care provision. So the private sector has a huge role to play in providing long-term care services. Many of our countries haven't started thinking about it, except maybe in China and Vietnam. So that's another area we look at quite closely.
Thank you very much for your responses. The question that we received from Professor Yoshino, thank you for your question. Health expenditure becomes extremely large facing with the COVID-19 and similar big diseases. On the other hand, in normal situation, health expenditures would be stable. What would be the way to cope with extremely high health expenditures? Would it be possible to borrow money to suddenly increase health spending to smoothen UHC? That is a question from Yoshino-sensei. Aparna, please.
So with COVID, we've seen a spike in health spending in almost all countries. And countries have indeed borrowed in order to pay for that additional health spending, in East Asia in particular. And as I said, pre-pandemic, East Asia Pacific countries had increased government spending on health, but relative to their GDP and compared to other countries of the same income level in other regions, East Asia Pacific countries were not spending as much, were not allocating as much public funding to health. So when COVID happened and there was a spike in services, there was increased borrowing for health. Now, what happens next is what we're all worried about the most. And this is why we've done those projections that I showed to you. Based on historical trends, we actually expect health spending to fall, having a negative impact on universal health coverage or progress towards universal health coverage. But in a pro-health scenario where countries actively allocate more than before to health, we might see health spending remain stable compared to before. But another thing about sustainable financing for UHC, particularly in our region, which is rapidly aging with growing burden of NCDs, technological innovations that drive up healthcare costs, spending better or allocating public health spending more efficiently will also be quite important for maintaining or sustaining universal health coverage.
Thank you for your responses. A question from Inoue-san. What do you seek the most in candidate when you are interviewing them? So this is perhaps related to the questions because the question raised because you're a hiring manager for the currently posted the health economist specialist position. So if you can also talk a little bit about the positions, that would be really appreciated. Thank you.
So the position we have open at the moment, the donor-funded staff program position, I think is the one you're referring to, would be based in Dili, East Timor. So Timor is really a very interesting country at the moment for us in terms of our program growth, because for the past 10 years or so, we haven't been actively engaged in Timor-Leste through operations. We've had small pieces of analytical work, but just over the last 2 years with COVID, and thanks to a JSDF grant, as well as a grant from the Health Emergency Preparedness Response Trust Fund, which I think Japan's also contributed to, we have these 2 small grant-funded operations to help respond to COVID and to help support the vaccine response. That has allowed us to engage much more with the government. In addition, we're also just finishing up a human capital review for Timor-Leste that's identified all of the different areas in human capital development that need more attention in Timor. So whoever's going into Timor in the next year or so would be going there in a context where re-engagement with Timor is happening, where we're able to work closely on health, nutrition, and then more broadly, the links with social protection, education, and so on, and possibly develop a new lending operation in Timor should the government be interested in going in that direction. So what would we be looking for? Well, obviously somebody who's entrepreneurial, who's willing to explore new leads, and work really closely with our health team, which is primarily based in Jakarta, to take advantage of these new openings we have in Timor-Leste.
Thank you very much, Aparna. You kindly responded to all the questions that we received from the viewers. So before wrapping up the seminar, any final words, perhaps encouraging words to those who might be interested in applying for the positions? Thank you.
Sure. No, I'm hoping that listening to this presentation, your interest is piqued and you recognize that this is an extremely interesting and dynamic region to work in, particularly in the area of health. So I'm hoping many of you will look into the Timor position, and even if that is not the right fit for you, I'm hoping there'll be other opportunities in future for you to work with us. But before I close, I would also really like to thank the government of Japan through all of the many investments that you make in the East Asia Pacific region. Through the World Bank, you've considerably enhanced our work. We're grateful to PHOD, JSDF trust funds, and in the many other ways that we collaborate with the government of Japan in the East Asia region. Thank you.
This morning, we had a pleasure of having Aparna Smana-san, the practice manager for health, nutrition, population sector in the East Asia and the Pacific region, connecting us from Sydney. Aparna, thank you very much for your time to join us this morning. Thank you.
Thank you. Thank you very much.
Great. Thank you very much. So next week, we are featuring the latest edition of the Europe and Central Asia Regional Economic Update, titled War in the Region. This is one of the hottest topics at this moment. This will start at 8 a.m. on Friday, April 22nd in Japan Standard Time. Please check our website on the details of the seminar, but also we have several other forthcoming seminars lined up already. Detailed information are posted on our website. Thank you very much for joining. Stay safe, stay healthy, and see you next week. Thank you.